Welcome to the MedTrak interpretation video for video ENG testing. This particular tape will concern itself with the interpretation of the various different portions of the video ENG and their implications with positive or negative findings. It should be mentioned that the oculography video ENG is now the most advanced form of electronystagmography testing, which depends upon computerized interpretation of a number of different data points as well as video recordings of actual eye movements and nystagmus. The first portion that we will discuss is the horizontal and vertical eye positioning with the pursuit or tracking tests. It should be mentioned that the pursuit testing is the most sensitive testing for central nervous system function, but does not localize the site of the lesion. It is the most sensitive test also to age-related changes in CNS function. The test paradigms typically include sinusoidal tracking at multiple frequencies and multiple speeds for a fixed velocity task or moving target. It allows continuous tracking of small, bright, slowly moving objects and requires sharp foveal vision for optimal results. The most common abnormalities encountered in this particular testing modality are decreased gain and saccadic intrusions. On the video screen, this computerized specimen demonstrates both the ideal normal target as generated by the computer, which is shown in yellow, as well as the actual patient data, which is demonstrated in red. As we see, the ideal target demonstrates normal uniform sinusoidal motion, which can be easily tracked. However, in the case of the actual patient data, we're seeing a cogwheeling type phenomenon, which, even though in this particular case the patient demonstrates a normal gain of 101%, because of the morphology, this is clearly an abnormal pattern and would suggest central nervous system disease. Again, the sites of lesion may also include lesions of the cerebellum, the cerebral cortex, also may be as a result of medication, overdoses, decreased visual acuity, as well as presbyostasis or a decrease in vestibular function, in this case central vestibular function with aging. It should be noted that normal gain is greater than 70 or less than 140% in the normal situation. And even though this particular patient exhibits a normal gain for the patient's age, because of the abnormal morphology, this is considered an abnormal testing result. It should be noted that this particular part of the ENG is the most sensitive to changes in age. And in fact, there is a decrease of 5% in gain for each decade over the age of 60. Additional examples of tracking or pursuit abnormalities are also presented, the first two of which demonstrate, as previously noted, the cogwheeling type abnormality, which demonstrates abnormal morphology, as well as in the first case an increased gain greater than 140%, which is abnormal. The next three selections demonstrate abnormalities in undershoots where the patient's eyes are not able to rise to the top of the target and to follow the target in a smooth type pursuit. These represent also common abnormalities. The next is an overshoot, which demonstrates that the patient's eye movements actually move past and beyond the top of the target. And again, the lack of a continuous sinusoidal type motion. The final abnormality demonstrates an inability of the patient to track the slow-moving object at all and results in no sinusoidal motion whatsoever. All of these are common abnormalities. The next portion of the oculomotor battery is the saccadic testing. Saccades are dependent upon the evaluation of rapid, accurate refixation movements with the eyes. They may be voluntary or reflexive, and they are typically used for tracking large, quickly moving, repetitive images. This particular type of testing requires full-field retinal imaging and stimulation, and the test paradigms that are utilized are random targets and predictable targets. Analysis has to do with the assessment of latency, velocity, accuracy, and asymmetry. In this particular tracing, we see the normal saccadic testing patterns as outlined in yellow, demonstrating again the large, quick-moving targets, as well as the patient data demonstrated in red. In this particular situation, we are seeing abnormal saccadic tracings, which consist of overshoots, of saccadic intrusions, and in fact some glissade or small catch-up type movements which are also abnormal. In addition to the abnormal morphology, we are also seeing that the velocity and the delay are grossly exaggerated, demonstrating abnormal findings from both the morphological and the numerical analysis. The following examples are a combination of both normal and abnormal forms of data. The first two tracings show normal saccadic movement, demonstrating a good square wave type configuration. And even though there are some mild glissades and perhaps some musculoskeletal movement, the ability of this particular patient to perform the saccade testing is normal. The next two examples constitute overshoots, where we can see that the patient's eyes have overshot the target or actually moved beyond the limits of the computer's ideal target. In the second example of the overshoots, we also see some abnormality in the patient's ability to become focused on the target, demonstrating two smaller saccadic tracings, both of which are abnormal. The next example is that of an undershoot, where the patient was not able to keep up with the moving large target, and therefore the tracing demonstrates that the patient was unable to focus their attention properly. The last two examples show an absolute lack of any saccadic motion whatsoever, which is completely abnormal and which represents a more profound central nervous system lesion. It should be noted that in the case of saccade testing, that both the latency and velocity are affected by age. In patients greater than the age of 60, there should be an adjustment of 10 milliseconds per age of decade greater than 60. In the case of velocity, this particular measurement should be adjusted downward some 10 degrees per second per decade over the age of 60. The next portion of the oculomotor battery is the optokinetic testing. This particular type of testing is again designed to demonstrate central nervous system vestibular pathology. It primarily depends upon the tracking of involuntary, large, slow-moving, repetitive type images where nystagmus or abnormal eye motion is actually normal and is induced by the maneuver itself. It requires a full field retinal stimulation which is necessary for true OPK testing. Foveal stimulation is not true optokinetics, and the patient should begin to feel like they are moving during the testing. The absence of nystagmus in this particular part of the testing is completely abnormal. As we're looking at the screen, the normal type of sawtooth nystagmus, which is expected in a patient, is demonstrated in yellow. The patient's actual response is demonstrated in red. In this particular case, the patient is unable to perform the optokinetic testing as demonstrated by the lack of discernible nystagmus patterns. And in this particular case, there is significant abnormality as the patient over a period of time cannot perform the optokinetic testing. In the vertical channel, we see also a complete lack of optokinetic response, which is clearly abnormal. This is an indicator of a non-localizing CNS finding, and it should be noted that if the tracking and second testing is normal, the optokinetic testing cannot be abnormal. It should be noted that in examination of the rightward and leftward beating nystagmus, that OPK testing to the right will demonstrate fast phase nystagmus to the left, and OPK testing to the left will demonstrate fast phase nystagmus to the right. In the following examples, we have demonstrated that a greater than 30% difference in rightward and leftward OPK is also abnormal, as well as previously noted absence of OPK tracings. In the first example, we see good sawtooth nystagmus both in the rightward and leftward OPK testing. This falls within the less than 30% range and is therefore a normal tracing. In the second tracing, we see a significant difference between the rightward and leftward OPK, demonstrating a greater than 30% abnormality. This, of course, is abnormal. This demonstrates a greater than 30% difference between the right and the left nystagmus in the OPK, and this is abnormal. In the third example, there is a significant difference of greater than 67% between the rightward beating OPK and the leftward beating. And finally, in the last example, is a complete absence of nystagmus, which, as previously demonstrated, is a clearly abnormal finding. In the case of OPKs, there is no age-related change in the scoring of this particular parameter of the test. The next portion of the oculomotor battery involves an assessment of spontaneous and gaze fixation nystagmus. In the case of spontaneous nystagmus, the infrared goggles are placed upon the patient and the patient is asked to look straight ahead. In the normal situation, the patient is able to look straight ahead without there being any nystagmus being present, even though sometimes muscular artifact may be noted. Once the fixation light is turned on, if in fact there was some spontaneous nystagmus prior to the institution of the fixation light, this should be diminished by at least 50% or in fact go away completely. In the case of spontaneous nystagmus, which does not suppress with fixation,